Hi friends, this is Dr. Pahuja. Welcome to developing an ER clinical case review program. This is from the Aerolib Healthcare Solutions, and you are viewing this on the Aerolib Learning Management System. I'd like to start off with a disclaimer. What we've used is CPT codes, which are a trademark of the American Medical Association. Interqual is a product of McKesson. We'd want you to pause and read the disclaimer before you go on the video presentation. Now, the peer review process, it needs to be objective. And what we want to do is implement an effective peer review process to improve healthcare delivery. We want to identify gaps in care delivery, identify gaps in physician education, and then reduce the risk in patient care with improving quality and safety. Our methodology is simple. We have board certified physicians. They have previous experience with peer reviews. And what we'd like to do is do at least 30 cases per provider. Again, developing a statistical significant number for the physicians, or the extenders of physician assistants and nurse practitioners. We'll go through some chart review criteria, and we usually have about 28 to 30 variables per case. Our goal is to reduce bias and increase efficiency. And so we've developed a case rating form with identification of the following. So where we find documentation lapses, where we find red flags in documentation, and then identification of human and system failures. The goal is to identify opportunities for improvement. Selection basis is very complicated, but I'll simplify it here. Each of our reviewers will select a few cases, and what we do is select cases from each decade of patient age that a provider is seeing, separated by at least 2-week period to remove the bias. We do monthly cases with concurrent and retrospective reviews, and then follow up similar DRG cases once a feedback education has been provided. So the output is in the form of a dashboard format. There are recommendations for improvement. We'll also assist with development of patient-oriented, evidence-based clinical practice policies. You can see this slide, and it talks with the number of audit variables. Our score is from 1 to 5, where 1 being excellent or superior in every way, and 5 being unacceptable or clearly inadequate, requiring remediation. So some of the audit variables are clarity of the note, problem list, chief complaint, review of system, physical exam, medical decision making, all part of the EM guidelines, appropriate T-sheet use, organization of the note, ED events in terms of medications given and consultation, whether the entries are legible, documentation of allergies and adverse drug reactions, lab and other testing which is appropriate, working diagnosis which is consistent with findings, plans of action, treatment, evidence of appropriate use of consultants, procedures, medical decision-making, nursing notes, review of old records, imaging use, whether the med sheet has been used appropriately. We want to make sure chronology of the note is maintained, whether informed consent is noted for all procedures and prescriptions, admission criteria, follow-up instructions if the patient is discharged from the ER, transcription accuracy, and whether the physician has reviewed the note. No inappropriate information is in the chart, no inappropriate alterations or omissions, medical necessity of services, and overall competence with accepted medical practices. From a sample that you see here, a T-sheet is being presented to you for page 1 and page 2. As we can see here, the date, time, age of the patient, race and sex has been documented, the HPI has been filled, the documentation is appropriately written, review of systems, past medical history has been completed, physical exam has findings check marked, and then findings of the abdominal pain location. They've talked about some progress notes after treatment and after CT scan has been available. Next page looks at imaging, labs, EKG, what the clinical impression is, and what the final status is. So we'll go over some of these points as we break them out. When we look at the HPI, on the right hand side, you can see this patient is presenting with 5 days of abdominal pain, has seen multiple specialists, no definitive diagnosis, and they've described the quality of the pain as cramping with location in the abdomen. When we look at review of systems, you have to be careful. If you have done all the review of systems, then it's appropriate to mark the box of accept, mark positive, all systems above reviewed and found negative. However, this does pose you to an audit if you have not done those systems when it happens in terms of post-payment reviews in the HPI, in the history and physical from the attending, or whether nursing notes document that the review system has not been done. When we look at past medical history, this has been filled out appropriately with hypertension, colitis, diverticulitis, duodenitis, hysterectomy. So all pertinent past medical history has been put in. Medications and allergies have been referred to the allergy note, and then social history has been marked appropriately. Physical exam has vitals that are appropriate, and all examination findings have been tick marked for non-abdominal organ systems. When we look at the abdomen, they have marked the location. They've marked as above, and this may be something that you want to further delineate on the quality of the pain, tenderness, location, radiation. So tenderness, bowel sounds, GU, and rectal may be something that needs to be put on. Neuropsych exam, progress notes, they've mentioned about CT abdomen, what the findings will be, and then the clinical impression of diverticulitis, inflammatory bowel disease, abdominal pain, disposition time, and what is being done for this patient. Now, when we collect this case for each provider, we calculate the raw score from the case based on the audit variables. This is then put into the color-coded scheme on where we find red flags in the documentation. So the greens of the ones are appropriate, but as you can see in case number B10900, which has been red flagged, there are a number of fives in working diagnosis not consistent with findings. So we have to be very careful why the patient's in the ER, what have we done for this patient, what is the lab imaging, what is our medical decision making, and then what is the final disposition. And then we do a broad view analysis where we calculate provider audit scores, error rates. We calculate the top 5 audit variables. So for one group, we've noticed that physical exam followed by chief complaint, counseling, review of systems, and medical decision making in that order, where physical exam was the number 1 audit variable. What we'd like to talk about is interventions. So these need to be clear and concise medical record documentation. This is critical to providing patients with quality care, and it's required for hospitals, providers, physicians to receive accurate and timely payment. Medical records report the care a patient received, records the pertinent facts, findings, and observations about the patient's health history. It also helps physicians, other healthcare professionals evaluate and plan the patient's immediate treatment and monitor the patient's healthcare over time. Now, healthcare payers may require reasonable documentation to ensure that the service is consistent with patients' insurance coverage and to validate the site of service, the medical necessity and appropriateness of the diagnostic and therapeutic services, and that the services furnished were accurately reported. So we'd like to emphasize that medical records should be complete, legible. Each should include the reason for the encounter, the relevant history, physical exam, prior diagnostic test, assessment, clinical impression, diagnosis, the medical plan of care, and then the date and legible identity of the observer. Now, moving forward, there's going to be an increased scrutiny of claims. And so this is essential for revenue protection, denial prevention. And when Medicare, the Medicare Access and CHIP Reauthorization Act introduced the merit-based incentive payment systems, there are a number of quality metrics that need to be followed, and documentation of those metrics is very essential. The value-based purchasing adjustment, where cost of beneficiary care is compared to the per capita cost, is dependent on what is documented in the record. Now, for the emergency room, there are 5 major categories of EM codes in addition to the 2 critical care codes. And as you can see in this slide, 99281 is straightforward medical decision making followed by low complexity. 99283 and 284 are moderate complexity, and there are subtle differences on what makes a case an 83 versus 84. And 85 is the medical decision making of high complexity. Critical care codes are 99291 and 99292. Most of this will be covered as we move forward during our series of presentations. What I'd like you to know is the 2014 EM frequency distribution of these codes. And as you can see, almost 75% of the codes are between 99284 and 99285. Critical care codes account for about 7.6%, whereas low complexity is less than 1%. What we'd like to do is you to look at your distribution pattern. CMS does have links to all states. However, the national ED visit level distribution falls under this curve. So what we've done is a continuous unbiased peer review. What we recommend is to be done annually for the next 5 years, at least 30 cases per year per provider for statistical significance, and then more clinical case reviews with post-feedback improvement. What we'd like to know is there improvement after we have identified the gaps in education and given the education? This is all in compliance with the Healthcare Quality and Improvement Act. We'd like to propose clinical and regulatory education on disease-specific topics. And while you're viewing this on the Aerolab LMS, there are a number of topics that you have subscription access to. We also do daily concurrent case rounds to help with point of care feedback. So some of the points that we'd like to focus on and what we'll be looking at is chief complaint. This needs to be documented on all charts. Now, when you put in history of the chief complaint or history of presenting illness, make sure you document on quality, location, modifying factors, severity, duration, timing, and context. Include associated signs and symptoms. Mention the mode of arrival. History should be from the patient, unless you have exceptions of an unreliable reporter, language limitations, or altered mental status. But all this needs to be documented on your T-sheet. So document all sources of information, whether it's from the EMS, from the nursing home, from previous records, private physician when you call them via phone, or with the family. Now, of to note is past family and social history is part of some levels. It's not required for level 1, 2, or 3, but must have one item from any of the 3 for level 4. Must have 2 out of the 3 for level 5 in critical care. Now, past history includes medications and surgeries, family history on what you think is pertinent to the presenting complaint, and social history again. If this is altered mental status, you want to know if there is drug abuse history. Now, review of system is needs to be in the form of components, and so most of your T-sheets already have these pre-built components in the review of system. There are 14 that have been listed in the EM guidelines. Now remember, review of system with positive responses should be documented. Otherwise, we can write all other systems reviewed in negative. Again, your T-sheet needs to be formulated in a way that is allowed. On a physical exam, this is based on organ systems. And so you need to document eyes, ENT, respiratory, cardiovascular, GI, genitourinary, integumentary, neurological, musculoskeletal, and hematological versus lymphatic examination findings. Now remember, in levels 2 or 3, they require 2 to 4 body areas or systems. Level 4 requires 5 to 7 body systems or organs. What we'll encourage you is to pause at this slide, look at some of the nuances on what an examination for an organ system should be, and then move on. On a physical exam, remember level 5 in critical care requires 8 organ systems, not body areas. And so body areas could be head, neck, chest, abdomen, back, genitalia, extremities, but organ systems are what we described in the previous slide. Medical decision making, this is by far the most important component in terms of medical necessity of that ER visit. So record all the tests or at a minimum the abnormal findings. Interpret the studies yourself. Simply listing refer to CT may not be the appropriate way. List the treatment options, the responses to treatment. So if you have someone for COPD exacerbation, you've given 2 or 3 DuoNep treatments, please list the response to that treatment. Record all consultations. If you've talked to the cardiologist, the gastroenterologist, cardiovascular surgeon, make sure that is part of the T-sheet. Quality of diagnosis is more important than the number of diagnoses. Mention the disposition. Mention discussions with the admitting team, the consultants, and the specialists. So need 2 of the 3 factors. Now 4 or more possible diagnosis or management options. Must also document whether the problem is improving, worsening, or the same. And then document oxygen administration, films that or abnormality in the films that contributes to the medical decision making. Now 4 or more elements of the data or tests need to be reviewed. So you can simply write in a report containing the results, but you need to interpret at least the labs and the x-rays. You need to document why there is a high risk of complication for morbidity or mortality. An EKG interpretation is essential in some of the chest pain, syncope, TIA cases, and you need to have at least 3 out of the 6 criteria. So you need to comment on the rhythm, the rate, the axis, the intervals, the ST segment changes, whether you compared them to prior EKGs, and then the summary of clinical condition. Now you can also interpret the monitor telemetry strip, which should include the rate and rhythm. Now in critical care, there are some key elements, and what I'd like to read is the 3 key elements of critical care. So 1, there is a high probability of sudden, clinically significant or life-threatening deterioration. So critical care, there are some key elements in defining critical care. 1 is there is a high probability of sudden, clinically significant or life-threatening deterioration. Now note, the presence of unstable vital signs is not part of key element 1. However, it may be associated with those life-threatening conditions. 2 is requires the highest level of physician preparedness to intervene urgently. So emergency physician care also can comprise of critical care, even though you may send this patient home a few hours later. Now, involving direct personal management, the absence of which would likely result in sudden, clinically significant, or life-threatening deterioration. So this is the basis of your documentation when you're providing critical care. Note that in critical care patients, these are unstable patients that are requiring treatment, or they may become unstable. They should be admitted, transferred. They may expire, and that needs to be documented in your notation. Time spent providing critical care needs to be documented. Now note, this does include interpreting studies, consultation, talking with the patient, family, talking with EMS. So these are bundled procedures where there is a review of the test, films, evaluation and treatment, and charting counts all of these factors. Now note, you must write the number of critical care time minutes. Now services bundled in critical care time includes cardiac output interpretation, chest x-rays, blood gases, interpretation of data, gastric intubation, transcutaneous pacing, blood draws, pulse oximetries, vent management, and family psychotherapy. This is a wonderful guide that CMS introduced for evaluation and management services. People on the LMS can pause, and when you have the PowerPoint presentation, just click here for the EM guide. It will take you to the link where CMS has the updated guides. You can go on to Aerolib Learning Management System, where you have a number of slides for this presentation that you can use for future reference. Getting onto the Aerolib Learning Management System, go on to aerolib.com, click on the bottom portion of Aerolib LMS. It will take you to your personalized subscription login page, and you can look at all these presentations that have been put on. There are a number of topics. So for example, if you choose acute kidney injury, it clicks you on the video presentation, references, PowerPoint slides. There is monitoring of what you have done, and your managers can track your educational experience. The free app of Aorta is available for the iOS and Android phones, where we've had more than 100,000 people interact on new regulations and guidelines. Current topics on the LMS consist of clinical and regulatory reviews of COPD, sepsis, acute kidney injury, pneumonia, CHF, seizures, abdominal pain, TIA, syncope, atrial arrhythmias, and this is what we talk about in most of these educational topics. So red flags in documentation, comorbid conditions, how it fits into ICD-10, how do we avoid setting off audit red flags. Other topics include acute respiratory failure, case analysis for audits, 3D mapping of clinical data, anatomy of a medical record, the Moon Notice, condition code 44, value proposition of a physician advisor program, and new topics of chest pain, MI, UTI, blood transfusion, MACRA, MIPS, perfect appeal letter, and HCCs. New videos that were added in January of 2017 include ALJ mock hearing with retired ALJ Bob Soltis, as well as 2 other presentations from retired Judge Soltis on proposed decisions and what actually happens when payments are denied and appeals happen.